oxide therapy. This is used to dilate the pulmonary arteries with pulmonary hypertension. So when there's really bad pulmonary hypertension, the blood is typically shunted past the alveoli. It's not picking up oxygen. So if you can get the pulmonary vessels to dilate, you're going to have more blood flowing to the alveoli and picking up oxygen. So once that happens, then oxygen saturation improves. So sometimes it's not just increasing FiO2, increasing P, trying to get a high mean airway pressure with your high frequency ventilation. It could just be that your pulmonary vessels need to be dilated to improve oxygenation. So this is, nitric oxide therapy is approved for neonatal pulmonary hypertension. It's used for other reasons, which is called off-label, but that's the main thing, is that it's used to treat pulmonary hypertension. So before I turn the lights off and go through the slides, there's a couple things to write down. Start off by writing capital N, capital O, like the word no. And then next to it, write nitric oxide. And then explain it. Pulmonary vasodilator. So it's a pulmonary vasodilator. NO, nitric oxide, is a pulmonary vasodilator. And then next, after that, write capital N with a 2, subscript 2, O, nitrous oxide, N2O, nitrous oxide, and that's an analgesic that creates euphoria during your dental visits, nitrous oxide. And then after that, write NO2,
what is it? I'm sorry.
analgesic.
Analgesic?
Yeah, so pain reliever, brings about feelings of euphoria. And then the third one, nitrogen dioxide, capital NO2, nitrogen dioxide. Nitrogen dioxide is a toxic gas. So it's not good to have nitrogen dioxide in human tissue. All right, so it's really important that when you're referring to nitric oxide, that you don't mess it up, because if you say nitrous instead of nitric, you're talking about a completely different chemical that has completely different effects. So we're talking about nitric oxide. So inhaling nitric oxide, it's a potent pulmonary vasodilator. And why does nitric oxide work so well? When it's inhaled, nitric oxide goes to open alveoli and dilates the blood vessels around the open alveoli. So does it make sense that if you've got alveoli filled with fluid, the nitric oxide isn't going to get through that fluid and into that alveolus, and then dilate the vessels going past that alveolus? That would be kind of defeating the purpose, right? If you have an alveolus full of infiltrate, you're not going to be able to oxygenate. So to have that alveolus have capillaries dilated, that would be a waste of time. But since it's breathing in, it's only going to alveoli that are open and patent. Now you've got vasodilation only occurring with the open alveoli. So your VQ mismatch becomes VQ matching. So the mechanism of action for nitric oxide is nitric oxide increases cyclic GMP, which leads to pulmonary vessel dilation. So when the inside of the cell, when cyclic GMP is produced, it'll cause that muscle cell to relax, like the smooth muscle around the capillaries will relax. It says it has a rapid onset of action, and it happens, it says within 30 minutes, but it happens fast. It's almost immediate. So maybe it's giving us that extra time just for all of the blood vessels to respond. So it happened, the pulmonary vasodilation happens almost immediately. So when it says less than 30 minutes, that means it's giving it time to diffuse to all the alveoli. Once the nitric oxide does cross over the alveolus and gets into the capillary where it's doing that vasodilating, within 12 seconds, it's already been metabolized by the body. So the half-life is 12 seconds. So within 12 seconds, most of it has been metabolized. So because of this, it has a minimal effect on systemic vasculature. So a question could be, when you give nitric oxide and it dilates the pulmonary vessels, doesn't it dilate all the vessels in the body and cause the blood pressure to drop? And your answer would be no, because by the time it reaches the capillaries, within 12 seconds, it's already been metabolized, so it won't affect systemic vasculature. So, is low blood pressure a side effect of nitric oxide?
No.
No.
Trying to think of all the possible ways to ask the question. And the metabolites are then cleared by the kidneys. So for mechanism of action, it wants us to go to inamax.com. Am I going too fast, or is it
No,
too
it's
slow?
it, you just mixed it with the other URL, so just repaste it.
They have really great videos, and everything is online. So if you start working in neonatal ICU and you have a baby, or you're going to be working with babies that need to receive nitric oxide therapy, you just go to the website to get everything updated and to refresh yourself. So this is the mechanism of action.
Explore the mechanism of action of Inamax, nitric oxide for inhalation. Hypoxic respiratory failure, also known as HRF, is a condition that occurs when the cells in the body are unable to receive enough oxygen. HRF is a serious condition for newborn infants. In term and near-term infants, the primary cause of HRF is blood vessels in the lungs that are constricted, limiting blood flow from the heart to the lungs. HRF results from various underlying pathologic conditions, including meconium aspiration syndrome, persistent pulmonary hypertension of the newborn, respiratory distress syndrome, pneumonia. Hypoxemia results from poor ventilation and/or poor perfusion. This image demonstrates the alveoli and pulmonary vasculature when there is low ventilation and normal perfusion. Due to the low ventilation, blood leaving the lungs is poorly oxygenated and can lead to hypoxemia.
So I guess the blue is the venous blood and the purple is a little bit of oxygen.
Pulmonary vasculature during ventilation. Ventilation recruits the lung and improves oxygen delivery to the lungs. Ventilation alone may not resolve hypoxemia. In neonates with HRF, hypoxemia can occur due to intrapulmonary shunt, in which pulmonary arterial blood reaches the pulmonary venous side without passing through ventilated areas of the lung, or extrapulmonary shunt, when right to left shunting of blood bypasses the lung through fetal channels. This shunting of blood leads to ventilation perfusion, or VQ mismatch. Hypoxemia persists. Because HRF involves the lungs and pulmonary vasculature, treatment should be targeted at correcting the poor ventilation and poor perfusion. Nitric oxide is an endogenous signaling molecule that is a potent vasodilator. Inamax is a vasodilator which, in conjunction with ventilatory support and other appropriate agents, is indicated for the treatment of term and near-term, greater than 34 weeks neonates with hypoxic respiratory failure associated with clinical or echocardiographic evidence pulmonary hypertension, where it improves oxygenation and reduces the need for extracorporeal membrane oxygenation, or ECMO. INOMAX should not be used in the treatment of neonates known to be dependent on right-to-left shunting of blood. Since nitric oxide is inhaled, it selectively dilates the pulmonary vasculature due to efficient scavenging by hemoglobin, has minimal effect on systemic vasculature. As an inhaled drug, it works with most modes of ventilation strategies. INOMAX must be administered through a system that does not cause excessive generation of nitrogen dioxide and that measures nitric oxide, nitrogen dioxide, and FiO2. INOMAX enters the lungs with each inspiration. Because INOMAX is inhaled with each breath, it is delivered in proportion to the degree of airflow. Therefore, INOMAX causes an increase in blood flow to the areas of the lung where airflow is best, allowing optimal gas exchange. The nitric oxide molecules travel into the alveoli and diffuse across epithelial cells. Nitric oxide then diffuses into the vascular smooth muscle adjacent to the pulmonary arterioles. Inside the smooth muscle cell, nitric oxide binds to the hemoiding of soluble guanylate cyclase, activating the enzyme guanylate cyclase. Then, guanylate cyclase converts guanosine triphosphate, or GTP, to form cyclic guanosine monophosphate, or cyclic GMP. Cyclic GMP is a potent messenger. Cyclic GMP activates various kinases that cause calcium ions to be stored in the sarcoplasmic reticulum and reduce the amount of calcium that can enter the cell through calcium ion channels. The activation of cyclic GMP-dependent kinases and the decreased concentration of calcium of smooth muscle cell relaxation. Smooth muscle cell relaxation leads to pulmonary arteriolar dilation and a decrease in pulmonary vascular resistance. Nitric oxide is also scavenged by hemoglobin to form nitrosyl hemoglobin, NOHB. Then nitrite, NO2-, and nitrate, NO3-, are generated from NOHB by rapid spontaneous oxidation of the heme iron, forming methemoglobin. Methemoglobinemia is a dose-dependent side effect of inhaled nitric oxide therapy. Therefore, methemoglobin levels should be monitored during INOMAX administration. Caution should be used when administering INOMAX with other drugs that can cause methemoglobinemia, regardless of their route of administration. The predominant nitric oxide metabolite is nitrate. Nitrate is rapidly cleared from the plasma via the kidneys. In turn, nitrate is excreted in the urine, which accounts for greater than 70% of the nitric oxide dose inhaled. In summary, the physiologic changes induced by INOMAX include selective dilation of the pulmonary vasculature, a decrease in pulmonary vascular resistance, and increase in pulmonary blood flow. Additionally, in combination with adequate ventilation, INOMAX decreases VQ mismatch. The net result is improved oxygenation. Please continue for indication and important safety.
So they did it with nice pictures instead of my black and white PowerPoints. Are you able to hear that okay? I'm expecting the speaker to come on from the overhead projector instead of from underneath the computer.
Yeah, we are.
So there is a side effect to having nitric oxide being delivered, and that is that methemoglobin forms. It's dose dependent, and what that means is the higher the level of nitric oxide being delivered, the more chances of methemoglobin forming. So dose dependent, higher the nitric oxide, more chances of it being formed. So it says to monitor methemoglobin after the first 8 hours of therapy, and then once a day after that. And if the methemoglobin level rises more than 5%, or the actual methemoglobin level is higher than 5%, that would be a reason to discontinue nitric oxide therapy. Because now you're going to be sacrificing oxygen delivery to the tissues if that methemoglobin is tying up all the hemoglobins. Another side effect that happens is nitrogen dioxide might form. And this forms if the flow of gas containing nitric oxide is stagnant. And that could happen if, for some reason, you turn the circuit off, the ventilator circuit off, and you turn off your nitric oxide. The nitric oxide that was in the circuit is now going to react with air and form nitrogen dioxide. And then when you turn it back on and you connect the circuit up to the infant, all of that nitric oxide could go into the infant's lungs and destroy tissue. So obviously, anytime you turn it on, you have to flush the circuit first. Another thing is a nitric oxide monitor will have a side port where you could hook up an amber bag and deliver oxygen and nitric oxide if you're bagging. But then when you turn it off and let the bag sit, then you're going to get that toxic gas forming, the nitrogen dioxide. So you have to turn it on, flush it a few times before you can actually bag the infant. The level of nitrogen dioxide is always being monitored, and you'll see a digital printout of the NO2 levels always. If it's greater than 1.5 parts per million, that's too much, and that's when it becomes toxic. The only extra notes I have is that nitrogen dioxide may form if the flow of gas containing nitric oxide is stagnant, and it happens within 30 seconds. So it's not like if you turn it off, turn the ventilator circuit off, and then turn it back on really quick, it's okay. Because within 30 seconds, you'll get the nitrogen dioxide to form. So this is the front panel of the monitor, and it's always monitoring the concentration of oxygen you're delivering, the level of nitrogen dioxide, and the level of nitric oxide. Is it okay to turn off nitric oxide delivery so you have good oxygenation? And you're wondering, well, maybe the baby will oxygenate well if we don't have nitric oxide running. So let's just turn it off and see if our O2 stats worsen. You can't just turn off nitric oxide because it causes a rebound effect where quickly removing nitric oxide causes spasming of the pulmonary vessels, and now you're going to have worsening oxygenation. So the only thing you can do is wean nitric oxide instead of directly turning it off. Even if the patients had no response to nitric oxide, you still have to wean it down to 1 part per million before discontinuing. I forgot to have you write some notes for this. So there's some things being monitored. There's the FiO2, nitrogen dioxide, and the dose of nitric oxide. Write down where it's being monitored. So there's a sampling port near the patient. There is a sampling port near the patient. On the inspiratory limb of the ventilator circuit. Gas flow is pulled from the circuit. Gas flow is pulled from the circuit. (230 mLs every minute. 230 mLs every minute. So that's where those numbers come from. So how much nitric oxide is delivered? Up to 20 parts per million. You start with 5 parts per million. This isn't in your notes, so you have to write it down. You start with 5 parts per million. You double the dose every 15 minutes. So you double the dose, Q 15 minutes. And check SpO2 each time. So if the saturation comes up into the range that you want it to be, then you keep that level where it's at. If there's no response, then you'll go. So if you go from 5 to 10 the first time, you go up to 15 the next time, and then up to 20. And if there's no response at all, then pulmonary vasodilation isn't making a difference, and so there's no response. Can you just turn everything off and take it out of the circuit? No, you still have to go and wean it slowly. Okay, and then also write down the amount, the nitric oxide gas, the NO gas, is billed according to time, not the dosage. It's billed according to time, but not to the dosage. The cost, I don't know if it's the same as it was last year, $147 an hour.
What?
$147 an hour. So what does it come out to be, like $3,000 a day? Is that crazy?
It's more now after hours.
How much is it?
I think it's like 180.
$180 an hour? Oh my God. Even 140 is beyond recognizable. What you do have to know is when it's not in use, you have to turn the cylinder off. If you have the machine turned off and the cylinder is still open, it continues to log the time. So it's not necessarily a test question, it's just a question at the bedside. When you're not delivering the nitric oxide, you have to go around the back and manually turn off the cylinder, because when it's open, that's how the patient gets charged. So you could have it sitting in a storeroom and the cylinder is open and it could just be racking up charges.
Wow.
So turn cylinder off when removing from the patient. So how fast can nitric oxide be weaned? You cut the dose in half each time. And this is done every 4 hours, which it doesn't say in your notes, so you have to add that. It says cut the dose in half each time, and this is done Q4 hours. And then when you get down to 5 parts per million, then you wean 1 part per million every 2 hours. Okay, and then in your notes, write this down. Is the decrease in NO being tolerated? So is the decrease being tolerated? Check SpO2. Check SpO2. Let me just read the sentence and then you can write it. It says if FiO2 has to be increased by 20%, then the patient is not tolerating the wean. So I'll read it slower so you can write it. If FiO2 has to be increased by 20%, patient not tolerating the wean. Patient is not tolerating the wean. Here's the picture. All right, so on the side, you've got a module that'll allow you to attach your ambu bag oxygen supply tubing and where you're delivering the oxygen and nitric oxide. And then, of course, you select the same parts per million that you're delivering through the ventilator circuit, and then you turn on your gas flow. And down here it says, flush before use. Do you know how to flush a self-inflating amber bag?
You just squeeze it.
You have to
That's the purge.
squeeze it, yeah. So when you're setting up the Inamax, you have to calibrate it first before you use it. And then how does it work? There's an injector module that sits on the dry side of the heated humidifier. And then you place a sampling port on the ventilator in the inspiratory tubing. So an injector module is the expense of the unit. Whoever created that had to use a lot of technology, because when you have a fast flow of gas, you're going to need more nitric oxide coming into the circuit. But then when the flow slows down, you need less nitric oxide. That's how it's going to make sure it always keeps so many parts per million. So that injector module is, you know, where the company is making its money. That's what they have patented. The sampling port on the inspiratory tubing, 15 centimeters from the patient, and it just shows some tubing going into like where the temperature sensor is, and then it pulls the gas from there and monitors it. All right, what's good to know is the cylinder of gas is mostly nitrogen, and it's got a little bit of nitric oxide added to it. So 800 parts per million of the cylinder is nitric oxide. The rest of it is just nitrogen. So when that gas is being added to the circuit, can you imagine how your oxygen percentage is being diluted a little bit? You're taking whatever FiO2 you're delivering to the patient, and now you're bleeding in this nitrogen gas that has nitric oxide in it. It's going to dilute the gas that's there. It's going to dilute the oxygen. So you never get a true 100%. If you had FiO2 100%, it's never going to say 100% on the monitor. And the reason for that is it's being diluted with this nitrogen gas that has nitric oxide in it. Okay, and then a 2-minute video at inamax.com. Click on support resources, and it's supposed to bring up video clips.
On-demand video clips.
Do you see it?
Scroll up a little bit.
Oh,
No, that's not good. Maybe-
Is it available
Yeah,
below?
closer to the right some more.
interesting. So is this page too big?
Look that one.
Here we go. Delivery and dosing. Ah. Shoot. I don't know if you can hear that. No. Okay, so It's just telling you that you've got the injector module on the dry side of the humidifier, and you can tell that this tubing and this sensor is monitoring the flow of gas and determining several times a second how to adjust the amount of nitric oxide flowing in based on the flow. So it's just a highly efficient device at looking at the flow and knowing how much to inject into it. And go forward. Okay, so what they've added to their nitric oxide cylinders is this infrared signal that communicates with their nitric oxide machine, because other companies were producing cylinders of nitric oxide. And of course, Inamax is losing out on a lot of revenue because people are using off-label nitric oxide for a much cheaper. So what they did is now you've got to have their cylinder, and the Inamax has to notice this infrared signal, otherwise it won't work. Let's see what else.
When it makes the world go round, it says. This one's it.
All right, it's still saying the same thing. The gas is coming from the cylinder going into the injector module. I think that's good, right? So the injector module sits on the heated humidifier, and what's on the inspiratory limb of the circuit? And there's something you put on the inspiratory limb of the circuit. What does that do? Yes, it's just sampling the gas. So it's good to know. When I'm looking at neonatal ICU and they first started using nitric oxide, and I'm walking around asking questions because I didn't get any training on it, and it's like, well, what is that tubing on the inspiratory limb for? And it's going back to the Inamax. Oh, that's what delivers the nitric oxide. So this is when I had students going through NICU, so I would tell everybody, okay, well, that's delivering the nitric oxide. Then ICARIA sent their rep here to lecture to you guys, and I found out, no, that's not what's delivering the nitric oxide at all. That's just the sampling port that's making sure that we're delivering what we think we're delivering. The injector module is actually over on the heated humidifier. So. During delivery of nitric oxide, what does the Inamax monitor? And it shows those three things. And that's it.